Hi, this is Erin from Educated Nurse and welcome back to our channel. Today we're going to do a lecture on one of my favorite topics aside from EKGs, and it's going to be on fluid balance and IV solutions, electrolytes, and then ABG analysis. So we're going to dive into those. They're going to be 3 separate lectures, so look for all 3 of them. And if you're struggling with this, definitely check out the Etsy shop. We've got study guides that breaks down all 3 of these things a little bit farther, and there's practice questions if you like the questions that we cover in the lectures too. Also, if you're new to us, make sure to follow us on Facebook, Instagram, and TikTok, and check back on our YouTube channel. We're putting up different topics from various different body systems every week, so check back there. And then lastly, if you're looking for any merch or gifts or stickers or anything, definitely pop over to the Etsy shop. We've got tons of stuff for all the healthcare workers in your life. All right, so let's dive in to one of my favorite topics. Here we go. So to start off, if you don't know me, this is just a little information about me when you can read about it on your own time. I'm also just going to include a disclaimer that all the information that's presented is really just for continuing education and training purposes. If you are working in a hospital or you're working in an EMS agency, you really just need to treat patients in accordance with your medical direction and your EMS and hospital policies, as it certainly could be different than the information that I'm providing you. All right, let's dive into acid-base balance and ABG analysis, one of my favorite lectures. All right, so acid-base is balanced and regulated by a few different things. First, buffers. Buffers are immediate chemical reactions. Buffers bind to our acids in an attempt to reduce acid. Buffers only work if the respiratory and renal systems are working properly, but buffers kick in right away. Respiratory also kicks in fairly soon. It reacts within minutes to hours, and it's our second defense mechanism against acid-base imbalances. Respiratory is the primary regulator for respiratory imbalances. However, it does kick in with metabolic, just like metabolic kicks in with respiratory. But it's the primary regulator for respiratory imbalances. It helps us regulate our CO2. I have always learned and I have always thought of CO2 as an acid. And I know some people will say, Erin, it's not an acid, but for my little brain, when I think about acid-base imbalance, I think about CO2 as an acid. Now, respiratory only contributes an acid to the acid-base imbalance. Metabolic contributes a base and an acid. Respiratory only regulates our CO2, which is an acid, and that's the only thing it kicks in. Metabolic. Metabolic reacts within hours to days, and it's our third defense mechanism. It is going to kick in and help us with acid-base imbalance through selective regulation of bicarbonate, which is a base, and hydrogen, H2, which is your acid. This is the primary regulator for metabolic imbalances. However, like I said with respiratory, it does help with respiratory issues as well. So those are your 3 main regulators: buffers, respiratory system, and your metabolic system. All right, so check out my little gingerbread man here, okay? So your little gingerbread man, like I said, lungs is where you've got your CO2, and again, I know it's not an acid, but I think of CO2 as an acid. It's our only regulator from the lungs, okay? Then, and again, this is not where all of these things live, okay? But I always think to myself, especially when we look at imbalances, where does a majority of your acid live? A lot of it lives in your stomach, if you think about stomach acid, right? So we throw up our stomach acid. Bicarbonate lives in our kidneys and our colon. So we poop out our bicarb, which is going to make more sense when we start talking about metabolic abnormalities, okay? So you throw up your stomach acid, you poop out your bicarbonate, and your lungs contribute an acid. So just remember this little gingerbread man when we move forward and we look at the imbalances. I want to just touch on ABGs just briefly. We're going to get into it a little bit more when we start interpreting them, but a normal pH should be 7.35 to 7.45. The normal blood is slightly alkaline at about 7.4. Anything lower than 7.35 is going to be acidotic. Anything greater than 7.45 is going to be alkalotic. Your PaCO2 is your partial pressure of carbon dioxide in the arterial blood. This is a good respiratory function indicator, right? So you're going to look at your CO2 when you're looking at respiratory function, and HCO3 when you look at metabolic function. But a normal CO2 is 35 to 45. Now look back up at that pH. It's 7.35 to 7.45, and your CO2 is 35 to 45. So they're very similar. So don't try and stress yourself out trying to memorize a bunch of different things. And if you ask me, should I memorize this? Absolutely. You should know how to interpret your ABGs. And I know they're probably in your chart or they're done for you, but I still think it's a really important skill to know and learn. HCO3 is your bicarbonate. This is a good indicator of your metabolic function. And bicarbonate is that base, right, that the metabolic system contributes. That's 22 to 26. Now, when I was in nursing school, I still remember my nursing instructor telling me, you have babies between the ages of 22 and 26. Babies and bicarbonate both start with B's. It's a little ridiculous. I had both my babies after that, but whatever. I still remember you have babies between the ages of 22 and 26. So bicarbonate. PaO2 is your partial pressure of oxygen in the arterial blood. That should be between 80 and 100%. And your SaO2, which is arterial O2 saturation, should be greater than 95%. All right, so first up is respiratory acidosis. So when you're looking at ABG changes, your pH is going to be low, your CO2 is going to be high, and you'll have a normal bicarbonate. Okay, so in respiratory acidosis, again, lungs, your CO2 is an acid. Don't get on me about it not being an acid. That's how I think of it. Acidosis, you're going to hold on to your acid, which is going to lead to an increase in your CO2. Okay, so things that cause you to hold on to your CO2 would be defects in lung function, atelectasis, pulmonary edema, or a PE. Anything that's going to make you hold your breath and hold on to that CO2, so hypoventilation. Everyone take in a deep breath. You're primarily holding on to your CO2 until you blow it out. So patients that primarily are going to hold on to their CO2 would be patients like COPD, emphysema, or patients maybe that are on narcotics, which is causing respiratory depression, right? That's going to make you slow down your respiration so you hold on to your CO2. Spinal cord injuries can also do it too. Asthma can go either way, acidosis or alkalosis, and it depends on what state they're in. Airway obstruction can also cause respiratory acidosis. Infection, pneumonia, bronchitis, those kinds of things. But anything that's going to make you hold on to your CO2, and if you have to sit there and hold and take a breath in to get yourself to think about it, do it. Okay? So treatment of respiratory acidosis, maintain a patent airway. So if you have to intubate them, do it. Oxygenate them. That's one of the easiest ways to fix this. Get them on some oxygen. They might need to have some BiPAP or CPAP to help force air in or force air out if they're not excreting that CO2 on their own. One of the very easiest things you can do is sit them up. Get them into a high Fowler or a semi-Fowler's position. Sit them up so they can breathe better. Increase their ventilation. So if they are vented, maybe you have to increase their respiration rate. You might have to suction them if the reason that they're holding on to CO2 is maybe they've got some mucus or inflammation from an infection or something. It's kind of controversial about giving sodium bicarbonate. There is some evidence to show that it doesn't always work, but if you're thinking about your CO2 being high and they're acidotic, you could potentially give them bicarbonate, which is a base, to try and even them out. But the evidence on that is kind of controversial. It's not always super reliable. The other thing too is, treat the underlying cause. If they have an infection, get them on some antibiotics. If they're respiratory depression due to opioids, give them Narcan to reverse that. So just get them ventilating again, and you should clear out your CO2 problem. Okay, respiratory alkalosis. Okay, so alkalosis, you're going to be low in your acid, your CO2. Your pH is going to be greater than 7.45. you're going to have low CO2, okay, and then normal to low bicarbonate. In respiratory alkalosis, your lungs, your CO2, which is your acid, is going to be low, so they're going to be alkalotic. You're going to be blowing off your acid, okay, so your acid's going to be low, your CO2 is going to be decreased. Things that cause you to blow off your CO2, I want everybody to kind of hyperventilate with me, okay, so just breathe heavy. Hyperventilation is going to cause you to blow off your CO2. Okay, so anything that's overstimulation of the respiratory system. Other things like fever, sepsis, which is a hypermetabolic state, liver failure, mechanical ventilation. So if your respiratory rate is set too high, you might be putting the patient into respiratory alkalosis. You might have to slow down that respiratory rate on their ventilator. Anxiety or panic attacks, so they're hyperventilating. Other medications that could cause respiratory alkalosis: aspirin, nicotine, epinephrine, and then other things could be a decrease in blood pressure or a PE. So again, if you're thinking about alkalosis, what are things that are going to make me lose my acid in my lungs and blow off my CO2? Anything that's going to put you into a hyperventilation state. How do you treat it? Again, ABCs: maintain a patent airway, intubate them if you have to, hyperventilate them. Excuse me, don't hyperventilate them, they're probably already hyperventilating. To treat hyperventilation, ABCs, paper bag, it used to be kind of the go-to just to kind of get them to slow things down, but retaining a lot of CO2 when you have them breathe into the paper bag can cause headaches, dizziness, and stuff like that, so just teaching them breathing exercises would probably be more appropriate. You might have to give them some IV potassium or calcium gluconate, and then mechanical ventilation, turn down your vent settings and get them to slow down their rate a little bit. If it's something where they have overdosed, you know, like Tylenol or aspirin or something like that, you would consider giving an antidote for whatever medication they might have done, and then treating and checking those electrolyte levels too. All right, metabolic acidosis. So in acidosis, your pH is going to be less than 7.35. It's going to be low. Your bicarbonate, which is a base, is going to be low. And you'll have a normal or low CO2. So you're holding on to your hydrogen, your bicarb is going to be low, your CO2 is going to be normal or low. You're going to have metabolic acidosis. The problem here is going to be with that acid in your stomach. What are things that cause you to hold on to your hydrogen or lose your HCO3? Well, diabetes, DKA, diabetic ketoacidosis, can put you into metabolic acidosis. High fat diet, again, which is kind of going to put you into that ketosis state where you're burning fat over carbs potentially. Malnutrition, excess lactic acid, too much exercise, seizures, heart failure, heart attack, lung disease, renal insufficiency, kidney injury, chronic kidney disease, severe diarrhea. So remember, things that have us hold on to our acid, so holding on to the stomach acid, and we lose the bicarb, we poop out our bicarbonate. So look at those little poop emojis. A lot of your base or bicarbonate lives in your poop. So if you poop out your bicarb, the only thing that's left is the stomach acid. So if you're pooping, the only thing that's left is your stomach acid, which is going to leave you in metabolic acidosis. How do we treat it? ABCs, watch for CNS depression. They might have level of consciousness changes. Monitor their INO. Get them on seizure precautions. Figure out what the underlying cause is. You might want to consider dialysis, diuretics, or bicarb injection. But like if your patient has DKA, you're going to treat them for the DKA and the acidosis is going to fix itself. Same thing with like malnutrition. Like I've seen tons of like alcoholic patients that are super malnourished. They come in, they're in an acidotic or ketotic state. You fix the underlying problem, you fix the metabolic acidosis. All right, metabolic alkalosis. So alkalosis, your pH is going to be high, greater than 7.45. you're going to have high bicarbonate and normal to high CO2 potentially. When you think about metabolic alkalosis, you want to think of things that are going to cause you to lose your stomach acid and hold on to your bicarbonate. And remember, your bicarbonate primarily lives in your poop and kidneys. All right, so what's going to make you hold on to your poop and your bicarb? Constipation is a big one. Then you also need to think about what are some things that make you lose your stomach acid. Well, we throw up our stomach acid. So nausea and vomiting can make us lose our stomach acid, and when we lose our stomach acid, the only thing that's left is our bicarbonate in our poop. Other things where you could lose your stomach acid if a patient is having an NG suction. The suction is going to suck up all the stomach contents, like the stomach acid. So if you suck up your stomach acid, the only thing that's left is your bicarbonate in your poop. So metabolic alkalosis, kidney failure, insufficiency, diuretics, especially your potassium, your diuretics that are going to make you excrete those potassium, GI suctioning, like we said, constipation, massive transfusions, antacids, and again, you throw up your stomach acid, so you're going to hold on to your bicarbonate. Treatment for alkalosis, monitor and support ABCs, watch for CNS depression, eyes, nose, safety and seizure precautions. Again, treat that underlying cause. You might need to consider dialysis again with these patients. All right, the teacher in me loves a good practice question. So, a patient has an NG tube connected to intermittent wall suction and is getting ready for transfer to another hospital. While getting a report, the medic student asks the nurse why the client's respiratory rate has decreased. What is your best response? Think about them. Okay, the correct answer here is B. So this patient, we just talked about how the NG will suck up the stomach acid, leaving them in an alkalotic state. So the patient is going to kick in and they're going to try and decrease their respiratory rate as a compensatory mechanism to hold on to that CO2, which is an acid, because the NG suction is sucking up the acid out of the stomach. All right, your patient has been in ICU on a ventilator for 3 days. The vital signs are as follows: pulse of 55, respirations 8, blood pressure 95/70, temp is normal, and O2 sat is 99%. Based on the vital signs, what condition are you suspicious of? D is the correct answer, respiratory acidosis. If you look at the patient's respiratory rate of 8, that's low. Normal respiratory rate is 12 to 20 in an adult. So if you have a patient who has a respiratory rate of 8, they're slowing down their respirations, they're holding on to that acid, respiratory acidosis. All right, when we look at interpretation of ABGs, the first thing that I always do, there's a lot of people that, and I don't mean to confuse anybody, I'll just say that straight off the bat. There are a bunch of people that like to do the Rome method, which I will show you on the next slide. But I personally have just learned over the years to just look at the numbers. So first thing I do, is the ABG normal? Are all the values within normal limits? The first thing I will do is look at the pH. Is the pH normal, acidotic, or alkalotic? If you figure that out, you're a 50-50 chance you're going to get it right. Then I look at the CO2. Is it low, normal, or high? Is it a respiratory or a metabolic problem? I'll look at the bicarbonate next. Is it low, normal, or high? Is that a problem? Then I'm starting to think a metabolic cause. Then I'm not going to hit on compensation here, but then you have to start to think about, are the other body systems kicking in? Okay. And then is there hypoxia present? That could key you in also that there's a respiratory problem going on. But we'll talk about this in a little bit. All right, like I said, some people really like Rome. For me, it took me a long time to figure this out. It just did not make sense to me when I was in school. Really, for me, I just looked at the values and figured it out based on looking at the pH, the CO2 and the bicarbonate. It really took me a little bit of time to figure this out. If you figured this out and this works for you, great. But Rome is respiratory opposite, metabolic equal. So when you're looking at respiratory, let's look at alkalosis first. In the alkalotic state for respiratory, pH is going to be high and the CO2 is going to be low. So they're opposites. Same thing with acidosis. The pH is going to be low and the CO2 is going to be high. In metabolic, the pH and the CO3 are going to be equal. So if the pH is high and the CO3 is high, it's going to be alkalosis. If the pH is low and the bicarbonate or the CO3 is going to be low, they're going to be acidotic. And again, whichever method you like works for you, do it. Like I said, I'm just a numbers person. I like to look at the numbers and try and figure it out. But if this works for you, great. Whatever is easiest for you. All right, we're going to do 4 different blood gas analysis questions. So I'm just going to have you look at these, see if you can figure them out on your own, and then after a couple of seconds or so, I will just kind of run through with you what they should be. So if you want, you can pause this as you go, but why don't you take a peek at the first one and see if you can figure it out. All right, so this first one here, let's kind of run through these. So the pH is 7.32. So right off the bat, we can tell that the pH is low. Because we know that pH should be between 7.35 and 7.45. So we know the pH is low, which equals acidosis. So if you at least got that, you know your 50-50 chance of getting it right here. The PaCO2, we know that CO2 should be between 35 and 45. So that is actually normal. So we know it's not a lung problem, which you can pretty much guess then it's a metabolic problem. HCO3, the normal value there should be 22 to 26. So we know that the HCO3 is low, so you're looking at metabolic acidosis. And your PaO2 and your SaO2 are normal. So low pH, low bicarbonate. If you're looking at Rome, it's metabolic is equal, so metabolic acidosis. All right, here's another one. Take a peek at it, see if you can figure it out, and then we'll talk about it. All right, so first of all, pH, 7.35 to 7.45, this is high, so you already know that it's alkalosis because the pH is higher than 7.45. Your PaCO2 is low at 25. We know that it should be between 35 and 45. So you already know if you're looking at Rome, respiratory opposite, metabolic equal. So our CO2 is low and our pH is high. You're looking at respiratory alkalosis. If you wanted to look at your bicarbonate, your bicarb of 24 is normal. Now your PaO2 is low. So that's something that needs to be addressed, but you know that this is respiratory alkalosis. All right, number 3, give this one a try. All right, so this one, the pH is low. We can see that. Normal 7.35 to 7.45. The pH here is low at 7.15, so we automatically know this is acidosis. Then let's look at our CO2. Whoops, that's high. 55 is high. We know it should be between 35 and 45. So 55 is high. So again, if you're looking at your Rome, respiratory is opposite. So respiratory acidosis here. You look at your bicarb is normal. So we know it's respiratory acidosis. All right, last one. Give it a whirl. All right, let's look at this one. So 7.48, we know that 7.35 to 7.45 is normal, so 7.48 is high, which puts them into an alkalotic state. The CO2 should be between 35 and 45, so that's within normal limits. It's not a respiratory problem. Then we look at our bicarb, which is 30. We know that 22 to 26 is normal, so our 30 is high. And if you look at Rome, respiratory opposite, metabolic equal. So the pH is high, the bicarb is high. You're looking at metabolic alkalosis. All right, here are my references. Thank you so much for following along with this lecture. If you're struggling with any of this, the metabolic acidosis, alkalosis, respiratory acidosis, alkalosis, ABG interpretation, and just kind of acid-base imbalance, we do have a study guide in our Etsy shop which breaks it down even farther, and there's over 20 to 25 practice questions in there, very similar to what we're doing here, which gives you a little bit more practice. Also, if you are in healthcare or a nurse or whatever, we also have a Etsy shop, and it's got merch for that healthcare person in your life. We've got t-shirts, cups, stickers, you name it, we've got it. So check that out. And if you ever have any questions or you're just not sure about something, please feel free to reach out anytime and shoot me a message and ask me a question. Thanks for following along, and we'll see you in the next video.